we'll discuss treatment options for acute and chronic pain. These treatment options are based on something called the pain cycle. This was developed by Dr. Ko of Stanford Medicine Pain Lab. It describes the initial trauma and resulting effect of that trauma that leads to a pain experience. In order to stop this pain cycle from continuing, we have reactive or medical care options and proactive or chiropractic care options. So first we have an injury. The medical care works to temporarily reduce or mask symptoms. If opiates are chosen as a treatment option, this can result in a negative pain loop that results in treatment actually causing more of an issue, but we'll go into this shortly. Chiropractic care works on reducing inflammation and improving body mechanics, soft tissue dysfunction, in hopes to break through this pain loop and stop the pain. To compare our pain treatment options, we have allopathic medicine or medical doctors and alternative pain medicine or chiropractors. Allopathic medicine refers to science-based modern medicine that uses medications or surgery to treat or suppress symptoms. Typical treatments include NSAIDs like Tylenol or Advil, steroid injections, opiates, or surgery. Dr. Ko from Stanford Medicine says that there's over 200 different medications that can be used and over 250 procedures. Chiropractic care is concerned with the diagnosis and treatment of mechanical disorders of the neuromusculoskeletal system, specifically the spine. The goal is to improve biomechanics, and several treatment options include spinal manipulation, physiotherapy, acupuncture, exercise, nerve mobilization, and postural corrections. So, allopathic medicine deals with anatomical structure, whereas chiropractic medicine deals with anatomical function. Medicine looks at the structural anatomy, basically fractures, tumors, or other lesions that could be responsible for pain. The first image is of a patient with severe low back pain. The medical radiologist reported that this was a normal x-ray. What chiropractors do is look at the function. As the patient experienced severe increased pain leaning backwards, I requested a stress view shown in the second x-ray. You can see the vertebrae shift from x-ray 1 to x-ray 2. What this tells us from a functional perspective is that there is ligament damage that is compromising the structural biomechanics. If we do not address this, the pain will never go away, as shown in the previous pain cycle slides, as continuous inflammation and altered biomechanics would be present. According to the University of Pennsylvania School of Medicine, medical care, specifically pharmaceuticals, work on blocking transmission at the spinal cord level. According to the American Academy of Pain Management, chiropractic manipulation works at supraspinal levels to change cortical and brain function and activate descending inhibitory pathways to allow for reduced pain or pain modulation. So which doctor is best qualified to treat chronic pain? Neither. Chiropractic education and medical education curriculum is extremely similar. Chiropractic doctors obtain more training than family doctors in several areas, including anatomy and neurology, and family doctors obtain more academic training than chiropractors in several areas, including biochemistry, psychology, and pathology. But there's very little specific pain education provided to either profession. So even though these professions are very similar, they're as different as apples and oranges. As medical doctors concentrate on reactive care to reduce symptoms of disease, and chiropractic doctors concentrate on proactive care to prevent symptoms of disease from occurring. So in regard to pain education, which profession is better? Again, neither. Overall, there's a lack of pain education throughout healthcare. The American Academy of Pain Management reports in the course of a 4-year medical education, the median amount of class time spent on pain management was 9 total hours in 4 years. In addition, American medical schools report 5 or fewer hours of education in pain. Elective courses were only available in 16% of medical schools. 80% of medical schools had no formal pain education, and only 4% of medical schools reported an integrated pain management program. In Canada, the CPSO has tried to improve this, but have allowed for a significant gap in education requirements. At first glance, 900 hours looks quite impressive as a requirement. However, if you read the fine print, this can include working in a pain clinic. So a new graduate without any formal pain education can apply for a job in a pain clinic, and after 3.5 months of work, will have achieved the 900-hour recommendation. And if we look at subspecialty training, while extensive, there's no mention of any training associated with chronic pain. And as most of us know, acute and chronic pain have completely different neuropathology. To further complicate this pain education, the Globe and Mail have reported that pharmaceutical companies have provided the majority of pain education materials to medical doctors in the form of textbooks and curriculum, of which none of the material was supported by clinical data. In fact, the University of Pennsylvania School of Medicine shows that issues and challenges in pain management include lack of education, underassessment and undertreatment, that the knowledge of treatment and options in neuropathic pain is extremely low, and misdiagnosis of pain based on lack of education happens quite frequently, with 30% of the time during severe pain cases, 53% of the time during moderate pain cases, and up to 82% of the time with mild pain. It's my belief that training in pain management allows for better treatment to patients. If you go on our website, under Services, and you scroll down to Pain Management Treatment, we've provided a video that outlines some of our specific pain management training, education, and experience for your review. So what is the consequence of undertreatment? Stanford Medical School Pain Medicine Lab has shown through fMRI studies that having 1 year of chronic pain atrophies the brain equivalent to 10 years of normal aging. So you have loss of gray matter due to neurodegeneration. This is the same thing that happens in dementia. Stanford has shown that this will affect your bilateral prefrontal cortex, your right thalamus, your posterior lateral thalamus, your dorsolateral pons, and your somatosensory cortex. And these areas of the brain are associated with maintaining focus and coherent speech, motivation, wakefulness, extremity movement, mood, breathing, hearing, taste, balance, and general sensory information from your body. So as we look at the pain cycle, first we'll discuss medical reactive care to address pain. So when an injury occurs, we start with inflammation, and then we look at allopathic medicine that can help try to break the pain cycle. Surgery. In the US, Baylor University Medical School reports 23.3 million surgical procedures are performed each year, and most, if not all, result in some form of pain. In fact, research in 2017 demonstrated that sham or fake surgery was as effective as actual surgery in reducing pain and disability. For specific surgeries, McMaster University has reported that they are not helping in the long run, but cost Ontario $31 million a year. The University of Pennsylvania School of Medicine shows 3 of the 7 most common causes of pain involve surgical intervention. In regard to surgery, as a patient, you have to decide if the short-term pain relief is worth the possible long-term consequence. But remember, when discussing treatment options, surgical success rates do not consider long-term outcomes, as this study shows. This study shows a surgical success rate of 86.6% at 2 months. However, at 72 months, that success rate was only 36%. Why? Because surgery looks at structural issues, not functional issues. And if we ignore functional considerations, as the pain cycle has shown, altered biomechanics will lead to continued nociception or inflammation, and continued pain will occur. So what does the research say about NSAIDs? Non-opiate analgesics like aspirin or Tylenol or Advil are considered NSAIDs. Basically, damaged tissue releases enzymes that stimulate local pain receptors. These NSAIDs can interfere with those enzymes and reduce inflammation and pain. The problem is research has shown NSAIDs have become a leading cause of hospitalization, a leading cause of disability, and have severe adverse effects, which have ranked fourth in leading causes of death after heart disease, cancer, and stroke. In addition, NSAIDs have been found to be ineffective if not provided in the right time frame and the right area. And the FDA has had to increase the risk warning to include heart attack and stroke due to the severity of side effects possible with usage. So when considering medication, consider this quote from Celeste Johnston from the Canadian Pain Society, the Canadian Pain Coalition, and McGill University. All medications, including non-prescription pain medications, have potential dangers. It is estimated that approximately 1,600 Canadians die yearly due to adverse effects of anti-inflammatory drugs, and that there have been recent warnings from Health Canada and the FDA in the United States regarding liver toxicity associated with acetaminophen use. What does the research say about injections? Research has shown that injections can directly interfere with healing. In fact, side effects after one shot can include altered vision, changes in mental status, and tissue death. And research has shown injections in the knee actually result in cartilage loss. This means you're speeding up the chance of developing arthritis. Multiple injections provide additional risk, including developing diabetes, high blood pressure, GI disturbances, osteoporosis, and psychological disorders. And very common injections for headache and neck pain, Botox, has shown to be ineffective for chronic pain. Next, we'll consider opioid treatment. What does the research say about opiates? Before we consider risk-benefit, we have to understand the strength of each opiate. The risks reported after this slide are based on morphine usage, which is the lowest opiate strength. If you've been prescribed or are considering a stronger opiate, the risk will most likely be greater than reported in this presentation. So there are two primary problems with opiate usage according to Stanford Medicine Pain Lab. The first is the actual effect on you. The research has shown that opiates result in decreased gray matter in the right amygdala. These changes occur after daily use for 1 month, and these changes have been shown to be irreversible. In addition, you can develop hypersensitivity, meaning that this treatment will actually cause more pain, and the treatment can be addictive. The amygdala's main function is responsibility for emotions such as anger, fear, sadness, and controlling aggression. So if you've noticed emotional changes after 30 days of opioid usage, your symptoms may be a result of your treatment. In regards to hypersensitivity, this information is from the American Academy of Pain Management Continuing Medical Education course. Once you take an opioid, you have a time frame of reduced pain. As you take that opioid, the time frame shortens, and you actually can feel more pain at the end of the usage, and this continues. Eventually, the benefit is very short, and there's actually a much larger non-benefit where you feel more pain. And after usage, over 30 days, it becomes very variable, the pain management. Lastly, addiction. According to Jack Mendel, President College of Physicians and Surgeons of Ontario in 2010, Ontario is in the midst of a public health crisis. The reason I chose this backdrop is because Canada has actually just approved legalized prescription heroin. Regardless of the rationale for this, we know for a fact that this will not help with pain. Why? The science shows that heroin usage heightens functional activity of the amygdala, which we just discussed. In addition, it affects the anterior cingulate cortex. The ACC is responsible for regulation of overall effect, and it contributes to regulation of autonomic and endocrine responses and pain perception. And this action seems destined to fail, as we're repeating the past. In 1898, Bayer Pharmaceuticals released heroin under the idea that it was a less addictive option than morphine. By 1913, they were forced to pull heroin from the market due to its addictive nature. Now, 107 years later, it's on the market again, and we're repeating the past. And it's not just heroin. Ecstasy was also approved by the FDA in 2016. Johns Hopkins Medical School has reported that the average death rate of opiate usage is 63,600 people per year, of which 25,440 were associated with medical doctor prescriptions. So if we look at the research, according to the American Academy of Pain Management, opiates have a 31.7% average chance of helping people reduce their pain in short durations of time. So as a patient, you have to decide if the possible short-term benefit is worth the possible long-term risk. We get to the second issue. The real problem is that this treatment can result in a host of secondary issues and require additional treatment. This slide was presented during a postgraduate continuing medical education course I took through Johns Hopkins School of Medicine by Dr. Walker. As she points out, the side effects of opiates require additional pharmaceutical intervention. The problem, besides the fact that you have to take additional drugs, is that we have no idea or research on how these drugs interact with each other in our body. So while there may be some short-term benefit regarding medical care, including pharmaceuticals, overall the American Pain Society has reported this will not help with neuropathic or chronic pain. Based on this understanding of pain, we need to undergo a paradigm shift that rethinks pain treatments and changes our current pain culture in order to help those. Again, if we look at the pain cycle, the usage of chiropractic can help the initial injury stage through inflammation control and the chronic stage through improved biomechanics and soft tissue function. Today I will be discussing these alternative therapies under the chiropractic umbrella. First, we have to understand how spinal manipulation works. The University of Alberta has performed an MRI to show how a joint manipulation works. As the distraction starts, you can see the white gas bubble inside the joint. As we continue, the manipulation occurs and the gas is released, taking pressure off of the free nerve endings. This is how a joint manipulation works. What does the research say about chiropractic and functional medicine? The American Academy of Pain Management has shown that chiropractic manipulation works at the level of the central nervous system to activate descending pain inhibitory pathways to modulate or reduce pain. Joint mobilization reduces chronic inflammation of muscles and joints, according to the Journal of Pain. And according to the International Association for the Study of Pain, there's an anti-hyperalgesia produced by joint manipulation, which appears to involve descending inhibitory mechanisms that utilize serotonin and noradrenaline. The Journal of Manipulative and Physiological Therapeutics in 2013 reported a Swiss study. The study included 50 patients with cervical disc herniations confirmed on MRI scans and orthopedic tests. The patients were treated by chiropractors who used spinal adjustments applied directly to the affected area observed on the MRI scans. After 2 weeks of treatment, more than half of the patients had significantly improved. By 3 months, 85.7% of the patients had significant improvements in pain and disability. Additionally, none of the patients experienced any adverse effects with this treatment. Another article by JMPT reported chiropractic adjustments were just as effective as epidural injections for patients with back pain without the risk. The findings show that chiropractic can significantly reduce pain in patients with lumbar disc herniations and is less expensive than medical treatments. And the University of Pennsylvania School of Medicine actually recommends chiropractic spinal manipulation in its continuing medical education postgraduate courses. So does Harvard Medical School. In regards to electric therapy has been shown to modulate or accelerate the anti-inflammatory process to reduce perpetuation that leads to chronic pain conditions. Electric therapy acts on an A-beta system, which is directly associated with chronic pain, and helps with muscle relaxation, decreased referred pain, and has minimal side effects. Unlike anti-inflammatory drugs, which block the inflammatory mediators or the precursors, electric alternating polarity stimulation appears to facilitate and support the physiological inflammatory process and minimize the time necessary for tissue repair. So what does the research say about acupuncture? Neuroimaging studies of acupuncture have noted stimulation-associated responses in several limbic structures, including the amygdala, cingulate cortex, and hypothalamus. This afferent somatosensory stimulation has shown positive effect in modulating centrally mediated chronic pain states. So what does the research show about exercise? As little as 2 minutes of daily progressive resistance training for 10 weeks results in clinically relevant reductions of pain and tenderness and increased muscle strength in adults with frequent neck and shoulder symptoms. So when we consider the pain cycle, research has shown medication can provide short-term benefit for acute pain, but is not meant to be used long-term and is not meant to resolve pain problems. And that's shown on the pain cycle as well. Surgery and injections have shown short-term minimal benefit for acute pain. Alternative therapy has shown to be beneficial for both acute and chronic pain, and the overall risk of alternative therapy is significantly less than allopathic medicine. Now you have the information to make an informed decision on your pain management treatment. Please feel free to email us with any questions or to schedule an appointment. Thank you.